Thank you. Okay, so welcome back, everybody. Appreciate you returning on time. I just want to make one more announcement. Elizabeth is going to finish her pressure ulcer staging talk between 12:30 and 1:30. We're going to then do the new pressure ulcer items where we go over the coding for each of the pressure ulcer items on the IRF PI. And then once again, I'm going to flip-flop the break and the Q&A period that are on the schedule for this afternoon. So the break will be at 2:15 to 2:30, and then the Q&A period will follow from 2:30 to 2:45. All right, Elizabeth.
Well, welcome back. I hope you all had a lovely lunch. Nutrition support is really important for preventing and treating pressure ulcers, so I think it's great that you had that opportunity to do that. Hopefully this slide looks familiar. This is where I stopped in terms of stage 2 pressure ulcers. And I want to come to an area that for some people is new information, and the National Pressure Ulcer Advisory Panel on their website, which you see below is www.npuap.org, put out this position statement in 2012 about what do you do about pressure ulcers that have cartilage in them. And that's because previous to that time there wasn't any guidance. Because I went through the definitions of stage 3 and 4 and noticed it said muscle, tendon, and bone. But the word cartilage did not appear in any of those definitions. So the NPRAP went on record as saying that the presence of either visible or palpable cartilage at the base of a pressure ulcer, although it's not included in the definitions of stage 4 pressure ulcers, that their opinion, and remember this is expert opinion, but it gives us a guidepost, if you will, as to the direction that we go in, that cartilage really serves the same anatomical function as bone. So therefore they have gone on record that if you have exposed cartilage, that you should be staging that pressure ulcer as a stage 4 pressure ulcer. So again, that's a relatively new position statement, and it'll help you in terms of what do you do about those pressure ulcers that do have exposed or palpable cartilage. So I wanted to point out to you that CMS agrees with NPUAP, so that when you look at the coding tips later on in terms of the CMS manual for IRF PI, that they do say that cartilage does serve the same anatomical function as bone, and therefore pressure ulcers that are not on the mucosa that do have exposed cartilage, that you would stage them as a stage 4. So I hope that that will give you guidance in terms of what to do about them. Depending upon your clinical practice, I can say that one of the hardest things for me to do is to get you a picture to show that, because there aren't that many. But at least for, as soon as I say that, somebody will say, but I have, okay? So that will help you. Now, unstageable pressure ulcers, if you remember prior to lunch, I told you that NPUAP does have a category of unstageable. And from a CMS perspective, there are 3 different categories that come under unstageable. And that includes pressure ulcers that are known, but they're underneath a non-removable dressing or device, but you know that there is a pressure ulcer. The second category, if you will, under unstageables, are pressure ulcers that have necrotic tissue, whether that is slough or eschar. Remember, that's the yellow stuff or the dark brown, blackish, darkish dead tissue that's in the pressure ulcer. Or that the pressure ulcer is unstageable because of suspected deep tissue injury. So all those 3, from a CNS perspective, are considered unstageable on the earth pie. So first I wanted to talk about the first category of unstageables, which is pressure ulcers that are due to non-removable dressings and devices. So you would code this, and after me, CMS is going to go into this in much more detail, and I'm not speaking for CMS, I'm speaking from a clinical situation here. When obviously you can't see the wound bed because you can't take off the dressing at the particular time that you need to be doing the coding, but you know that there is a pressure ulcer underneath that device or underneath that dressing, and you can't declare it with a numerical number. And I think that's a really important notion, that at this point we can't commit to a number, and that's why we're in the unstageable segment of pressure ulcer classification or staging. So here are some examples here. Obviously, one of the areas would be a cast that you can't take off, but you know that there's a pressure ulcer underneath it. Let's say that the person here with the cast had a pressure ulcer on the heel, for example, and for another reason the person had a cast on the area. You know that there's a pressure ulcer there, but you can't stage it at that particular moment. And then there are other dressings that are kept in place for several days, as you might see on this systems here. But at some point, they're going to be changed, and they're going to be removed so that you would be able to identify what stage the pressure ulcer is. But again, it may not coincide for when you need to be filling out your earth pie form. And that's why you might be using unstageable due to a non-removable cast or dressing or orthopedic device. Okay, so NPUAP's definition of unstageable really looks at full thickness tissue loss in which the actual depth of the ulcer is completely obscured. So from an NPUAP point of view, they don't care whether it's that yellow, tan, grayish, green, or brown slough. Remember, the colors can be different. Or the darker, harder eschar, tan, brown, or black in the wound bed. But remember that the definition goes on to say that the slough or the eschar has to be removed till you can see the wound bed, enough of it so that you can say whether you're dealing with a stage 3 or a stage 4. Remember, it's based on the tissue type. NPUAP does go on to talk about a specific type of unstageable pressure ulcers, and that has to do with these pressure ulcers that are on the heel. And they give guidance in terms of that what they call stable pressure ulcers, those that are dry and intact without erythema. Okay, so once you see redness around the unstageable pressure ulcer, or you see fluctuance, which is the fluid in the tissue around the edges of the pressure ulcer, that's a different case. But if it's stable, they basically say leave it alone, according to NPUAP, that it's a biological natural cover, and don't remove it. Now here's CMS's, and again what I tried to do was to cover up that's what these red boxes have to do. So the second unstageable definition under CMS for earth pie has to do with unstageable due to slough and or eschar. So pressure ulcers that are known but not stageable because the wound bed is covered by slough and or eschar. So in order to stage a pressure ulcer numerically, you have to be able to see the wound bed. So to declare with a number, a numerical stage, you have to be able to see or palpate the depth of the wound bed. So I want to go to the next slide to blow up for you more some of the coding tips under this area. So pressure ulcers that are covered with slough and or eschar should be coded as unstageable until the true anatomical depth of the soft tissue damage, in other words, assigning a number, which is going to be a 3 or a 4, can be determined. only until enough of that slough or eschar is removed so that you can see the anatomical depth of the soft tissue damage involved can you assign that numerical stage or number of the wound. CMS does agree with NPUAP in terms of the stable eschar, that dry, adherent, intact without edema or fluctuance. And this is the definition of fluctuance, in case somebody was saying, I missed what she said about fluctuance. So this is a word that describes the texture of that wound tissue underneath with unexposed fluid. So it's like you can feel the fluid wave under the surrounding tissue around that pressure ulcer. So on the heels, it serves as the body's natural biological cover and should only be removed after careful clinical consideration. Very important now, ruling out ischemia, particularly on pressure ulcers that are down on the heel. If you don't have blood flow getting down to that heel, you should be hearing the word caution, caution, caution in terms of debridement. And that you need to be consulting with the patient's physician, nurse practitioner, physician assistant, clinical specialist, or whoever in your state is allowed by licensure laws to declare a medical diagnosis. So you don't want to do this alone, as for instance, if you're the staff nurse. You want consultation. I'll say it one more time. Staging is complex. It's not easy to do. And I think one of the things that sometimes we've been reluctant to do is to get consultation and to ask somebody else's opinion in terms of what I'm looking at. Is it really the stage that I think that it is? Is it really a pressure ulcer in terms of the etiology? So again, some of the coding tips that you might want to think about. Once the pressure ulcer is debrided of enough slough and or eschar so that you can see the anatomical depth of the soft tissue damage within the wound bed, then you can assign a numerical stage number to it. And again, CMS tells you don't have to have it completely debrided of all the slough or eschar in order to restage that pressure ulcer, meaning, and I want to be very, very clear here, when the word restage means here, it means going from the term unstageable to a number initially. And that number, because it started off with unstageable and it had slough or eschar, is going to be either a 3 or a 4. Okay, NPUAP, the sixth category that they had is suspected deep tissue injury. And you can see some clinical examples here. These are purple or maroon areas of discoloration on intact skin, or it can be a blood-filled blister due to damage of underlying soft tissue from pressure and or shear. And there's two examples. The one from the attacked skin is from Dot Weir, and the one from the blood blister is from Cindy Labish. And again, NPUAP goes on to say that the area may be preceded by tissue that is painful, firm, mushy, boggy, warmer, or cooler than the adjacent tissue. Now, when you rely only on color, deep tissue injury is difficult to see or detect in individuals with dark skin tones. And the whole evolution of DTIs, we really are trying to get a better idea of the evidence base here, but it may evolve further and become thin covered eschar. It can be rapid to expose the layers after a couple of days of the skin being intact. Now here's CMS's definition of unstageable pressure ulcers due to deep tissue injury in evolution. So that pressure ulcers that are unstageable due to suspected deep tissue injury in evolution are pressure ulcers with suspected deep tissue injury that present as purple or maroon areas of discolored intact skin due to damage of underlying soft tissue. It does go on to say that the area can be preceded by tissue that's painful, firm, mushy, boggy, warmer, or cooler as compared to that adjacent tissue. They do give you a guidepost that deep tissue injury can be difficult, again, to see in individuals with dark skin tones. And one of the tips they say, once the suspected deep tissue injury has opened to an ulcer, you can reassess it and give it a numerical stage number at the appropriate numerical stage. So here's some steps for assessment. You want to examine the area adjacent to or surrounding a pressure ulcer that presents as a blister for any evidence of tissue damage. So if the tissue adjacent to or surrounding the blister does not show, and that's Elizabeth Aiello's bolding for you, okay? Signs of tissue damage, i.e. the color changes, the tenderness, the bogginess, the firmness, the warmth, or coolness. So temperature changes, hot or cold, do not code as suspected DTI. In darker skinned individuals, the area of injury is probably not purple or maroon, but rather darker than surrounding tissue. So again, you need to know the person's natural skin tone when you're using color as a characteristic to look at pressure ulcer staging. So, where do you think most DTI ulcers are located? Figures after lunch, everybody's blood glucose level is rising, you get sleepy. So I put in an interactive question. So you can write down which answer you think it might be, whether you think it's buttocks, sacrum, heels, the ankle and the foot, or the elbow. And this is based on, again, published data. This is not CMS data that was published in 2010. So here's the numbers. So almost a little less than half are on the heels. So when you think of DTIs, think heels for patients. And again, when you think about that blood flow getting down to the heel area, that's probably no surprise that a lot of them are down there on the heels. So the question is, what about the definitions about pressure ulcer staging? Are they clearly differentiated? So I put side by side the definitions that you've already seen here just to show how not easy this is. So if you look at the definition of a stage 1 compared to deep tissue injury, I have color-coded the terms that are identical. Painful, firm. Now, come along with me. Would you think mushy and boggy are the same as soft? I think they are, although from a medical standpoint, you may not agree. So I'll give that one up. Warmer and cooler. So at least 4 of the 5 terms are identical. So no wonder out there, particularly when generalists, non-wound care specialists, are trying to differentiate between stage 1 and deep tissue injury, it's not so easy for people to get this right. And that's why I will say one more time, I think that this is where consultation is really helpful, because it's taking that definition and then applying it into clinical experience in terms of what people are looking at. So here's the CMS definitions side by side for you, again, to look at. So we have warmth in green. We have coolness or cooler. I would say those are identical. Firm in purple, firm. Boggy, boggy. Now, in stage 1, CMS includes pain and itching. So that's a little bit different. And that's why CMS does go on to say that relying on only one descriptor to distinguish a stage 1 from suspected deep tissue injury is not adequate. Never rely on just one thing. You need to be much more comprehensive, So the descriptors that are similar for these two types of ulcer are temperature, warmth or coolness, and tissue consistency, firm or boggy. So once again, think a little bit more holistically here in terms of what you're looking at to differentiate between a stage 1 and a deep tissue injury. Now, blisters. I have to say I always get lots of questions about blisters. And probably the most frequent question that I get is, what am I looking at when I look at a blister? Now, if you were to look in the definition in a medical dictionary, it would say that it is an area of the skin within the epidermis where you have a collection of fluid. Okay, so you have some fluid that is collected between the epidermis and the dermis, and that lots of medical conditions, they may not use the word lots, okay, but a variety of medical conditions can cause blisters. So the first thing is, when you're looking at a blister, you cannot immediately say that this is a pressure ulcer. And that's why, once again, holistic evaluation, when you're trying to get the etiology right, and then look at staging. And remember, staging is only one characteristic of describing a pressure ulcer. There are other things, but I was asked to talk about staging, so that's what I'm focusing on. So if you see, for example, things that can present as a blister, so here's a pressure ulcer that presented with yellowish fluid underneath it. But let's look at some other things. Certainly herpes can present as blisters. Bullous pemphigoid, which is a skin condition. Again, fluid-filled blisters on limbs, for example. All right, so this is not a pressure ulcer. This is a skin condition that people can get. So you don't want to classify that as a pressure ulcer. Here's somebody with a burn. Nice fluid-filled blisters. The hand is an unusual place for somebody to get a pressure ulcer. Doesn't mean that you can't have one. But sometimes location, should clue you in. And that's why, remember when I said about the etiology, I said history? So you would need to ask the person. I mean, if the person said, yeah, I had my hand on something hot, you would think burn. So that's why history is important. And here's epidermis bullosa, or EB, which again is a skin condition where people have problems with their collagen. They're born with a deficiency in their collagen so that the skin blisters up and then ulcerates down. Okay, and there's lots of different kinds of EB out there and tends to be pretty diffuse over large body parts. And again, one of the things that should clue you in is that pressure ulcers are usually localized over bony prominences. But you can see lots of different things, lots of different blisters can cause skin problems. They're not all pressure ulcers. So here's NPUAP's definition side by side of the blisters, because blisters and NPUAP are in two different definitions. They're in the stage 2 and they're in the suspected deep tissue injury. So that for the stage 2, it can present as an intact or open ruptured serum-filled or serosanguinous-filled blister. Whereas from NPUAP's definition, the blister is blood-filled. That's the CMS, that's the NPUAP definition. Now remember that we have very little evidence and data out there about DTI. So CMS has looked at the different, the little bit of data that's out there, and has looked at some of the clinical guidance that people have given. And what they have said is that for stage 2, it may present obviously as an open wound without slough, but also it can present as either an intact or an open ruptured blister. DTI can present as an intact blister. What they ask you to do, and these are my words, you can read the exact words that are on here on the screen, so I'm just going to put this into Elizabeth Aiello's words, okay, is that when you have a situation where you have a pressure ulcer that presents as a blister, you need to be holistic and to assess the surrounding skin for signs and symptoms of deeper tissue injury, regardless of the color of the fluid that's in the blistered pressure ulcer. So if you find that there are signs of deeper tissue injury, and what are they according to CMS? Color changes in the surrounding skin, tenderness, bogginess, firmness, temperature such as warmth or coolness. If those signs are present, regardless of the color of the fluid, it's a deep tissue injury. If those signs are not present and you have a blistered pressure ulcer, then it is a stage 2. Remember what I said before lunch. CMS has adapted, not adopted, the NPUAP definitions. So this is a figure which I published not for IRF but for long-term care in 2010 for Section M on their MDS. And I put it in here because I think it is a quick little summary that will help people, because I have to say, I almost always get a question about blister pressure ulcers. It is one of the areas that people have lots of questions about, because I believe that this is a difficult concept for everybody to get straight. So that's why this is a quick little enabler that was published in September 2010 in an article by myself, Dr. Levine, who's a geriatrician, and Sharon Roberson. Okay, so in acute care it's very different, but long-term care, which would equate to the regulation for IRF, that you need to look for the signs of deep tissue injury. If there are no signs of deep tissue injury and it's yellow, then it's a 2. If there are signs of deep tissue injury and it's yellow fluid in the blistered pressure ulcer, it's unstageable, DTI. If it's blood-filled and there are no signs of suspected deep tissue injury, it's a stage 2. If there are signs of deep tissue injury and it's blood-filled, then it's a deep tissue injury. So again, that's a quick little summary enabler. It doesn't give you all the other information I gave you, but it's a quick little bedside enabler for people. Okay, so then what I did is I put together for you at a glance, so this might be, again, a quick little enabler for staging to help you in the IRF setting. So if the skin is intact and it's non-blanchable erythema and lightly pigmented person, it's going to be a stage 1. If it's an open shallow wound with no slough, no slough, no slough, no slough, no slough. Or it's an intact or ruptured blister with no signs of tissue damage in the surrounding skin, it's a 2. If it's full thickness, you can have some necrotic tissue, either slough or eschar, but I can still see enough of that wound bed that I can see the tissue. There's no bone, tendon, muscle, it's a 3. For full thickness, I can have necrotic tissue, but I can still see the wound bed, bone, tendon, muscle, and you could add in here if you want cartilage, because remember we said that cartilage is also possible, it's a 4. If it's known pressure ulcer underneath non-removable cast dressing or medical device, it's unstageable. And it could also be covered with eschar. If it's purple maroon discoloration of intact skin and there are signs of tissue damage in the skin surrounding that blister pressure ulcer, regardless of the color of the fluid, then it's a DTI unstageable. Again, that's a quick summary. It's not all comprehensive. Again, this is data out there just to show you what's been going on in terms of staging in data that's been reported out there in the literature. You might say, wow, what happened between 2007 and 2008? Because there's a change in the stages that have been reported. Stage 2s have remained more or less stable, 38 to 37 to 36. Stage 3, 8777. Stage 4, 7767. But look what the big changes were between stage 1 and SDTI. And that's because the NPUAP had, in 2007, put forward the revised staging system to identify deep tissue injuries. So probably the decrease, and I want to emphasize the word probably, stage 1s went down, but you see an increase in deep tissue injuries because people were able to more clearly identify stages, because we now had a category that we didn't have prior to that to describe what was going on with the pressure ulcers. And you can see Unstageable has remained more or less consistent over the time frame. Now, what about devices? We know that people can have a variety of devices, and certainly comprehensive skin assessment is important to look at what's under those medical devices, drains, tubes, etc., so that you can look at skin damage. So comprehensive skin assessment is important. Now, NPUAP, again, on their website, www.npuap.org, has put out a position statement about pressure ulcers that are on the mucosa. And as you can see here, they have defined these as pressure ulcers that are on the mucous membranes with a history of some medical device and used at the location over this ulcer or skin injury. And they give a variety of examples of medical devices. The important thing is when you are on the mucosa, you no longer have the ability to keratinocyze. It's not the same as skin. So therefore, you cannot stage this because you're not dealing with skin. You're dealing with mucosa. So they give guidance that you cannot stage pressure ulcers on mucosa. So CMS has provided guidance in EarthPie about what do you do about skin injuries of pressure ulcers that are on mucosa. You know, lips, for example. Okay, that's soft tissue. And they have said, do not stage mucosal pressure ulcers from medical devices. And the reason why is because you can't do those anatomical comparisons that I've been talking about for stage 1, 2, 3, 4, and unstageable. And as you'll hear later on, you don't report that in the pressure ulcer section. They are a different kind of a skin injury. They are not reported as a pressure ulcer. What about pressure ulcers that have been treated and they've had a surgical flap? Are they still a pressure ulcer? This is a common question that I get asked a lot, and the answer to that is no. This has now been converted to a surgical wound. It is not counted as a pressure ulcer. And this is a clinical example from one of my plastic surgery colleagues showing the healed flap on this particular pressure ulcer. And this goes back to the idea that you do not reverse stage pressure ulcers. The NPUAP position statement has been around for a long time, many, many years. It goes into detail talking about that you don't backstage or downstage or reverse stage, whatever word you want to use to describe going from a 4 to a 3 to a 2 to a 1. So you don't go in reverse order of numbers as the pressure ulcer heals, and the reason why you don't do that is it's physiologically inaccurate. As a 3 or 4 fills in with granulation tissue, it's not the same as the original muscle, tendon, or bone or subcutaneous tissue that was in that was in the wound. And that's why you can't go backwards. That's why there's a big do not over the stage 1, okay? So when you see a pressure ulcer, and you can see that black eschar heel, and that was deemed to have adequate ischemia, remember? Okay, it did not have ischemia, it had adequate blood flow, and you can see the evolution of it, so that once it became unstageable, and you could see enough of the tissue, and that's a judgment call that we talked about, when you feel that you can commit to a number, and you're going to be committing to either a 3 or a 4 here, because once you have eschar, you have full thickness tissue loss, or slough. You have full thickness, at least as of today, May 12, 2014. That is our current thinking. So as the pressure ulcer heals, do not reverse stage or backstage. So how would you document this? This is a healing stage 4 in this particular case. This was down to the bone. You are looking at the photo. You don't have the advantage of palpating this wound. Remember, it's more than visual inspection. You'll have to take my word for it that you could palpate the bone on this pressure ulcer. So as it healed, it would be classified at the highest numerical stage. In this case, it was a 4. So until it is healed, this was a 4. So when you went from unstageable, when it was necrotic, and you declared it as unstageable because of eschar, and the first time you could see enough of that wound bed to say it was a 4, has it worsened? The answer is no. No, no. The first time you declare the numerical number from an unstageable pressure ulcer covered by eschar or slough, it has not worsened. Okay. So I have spent a lot of time talking about staging, which is one characteristic of describing pressure ulcers. And it's an important part of coding, as you'll hear from CMS. I thought it would be a little bit of fun to do a skin and wound quiz, and then I'll take some questions that have come in, so it'll keep us on time. So, and again, you only have the advantage of visual inspection here. So if you get it wrong, remember that this is a unidimensional assessment that I know that you would have wanted to palpate. Is that correct? Yes. Okay. So how would you stage this wound? So I'll give you a second to look at this. And this is on the sacral area in case you can't identify the body part from the photo. I'm not going to ask, well, if the live audience wants to raise their hands, you could play along with me in terms of how many of you would think it's a stage 1, a 2, a 3, a 4, a DTI, or unstageable. So here's the answer, and again, you have the answers at the end. This was indeed a pressure ulcer, and if you picked unstageable, I would agree with you. This is probably the best category to pick at this particular time. Okay, how would you stage this wound? A 1, a 2, a 3, a 4, a DTI, or unstageable. And again, I realize you are limited by visual inspection. So I'll give you, those of you at a distance and those of you here live, looking at this, just a moment to look at this wound before you declare this as to what you want to put this. And this was declared to be a pressure ulcer. It was a stage 4. For those of you who are here, you probably could see a little bit of slough, but this is not enough that you would in my opinion, Elizabeth Aiello's personal opinion, to say this is unstageable. I mean, I think you can see the wound bed here, and you also can see this area here, which is fairly deep, so that you're into muscle, and if you palpated this, you could feel the bone. So the best answer here was a 4. Okay, what about this? This is in the buttocks area and the sacral area, in case you couldn't identify the body part. How many want to say a stage 1, a 2, a 3, a 4, DTI, or unstageable? I'll give you a second to use your clinical skills. The answer here is this was not a pressure ulcer. This was moisture-associated skin damage. Do you stage moisture-associated skin damage using the NPUAP or CMS guidelines? No. No, 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 no. So remember that little table I gave you in terms of, that was a quick and dirty, if you will, criteria. It is not all-inclusive. And I will tell you again, in this sacral area, many moisture-associated skin damage from IAD, which stands for incontinence-associated dermatitis, get confused as stage 1 pressure ulcers or DTIs, because people, need to learn the nuances and the difference between them. Okay, how would you stage this wound? Stage 1, stage 2, stage 3, stage 4, DTI, or unstageable? Again, this is on the sacral area. I realize the lights are a little bright on the photo, so it might be hard for you to see. Hopefully, if you've downloaded them, it's easier. So the first question is you always ask yourself, is it a pressure ulcer, right? Because right now you're probably saying, oh, Elizabeth tricked us with one question. So let me first make the differential diagnosis about the etiology of the wound. You were probably thinking that, right? So this is a pressure ulcer. This was a 3 because we couldn't see muscle, tendon, bone, and palpate it. Okay, what about this? This is a foot in case you can't identify the body part. So is this a stage 1, a 2, a 3, a 4, a DTI, or an unstageable? And if you're wondering why the person is assessing and pinching the toe there, that's Stemmer's sign, which helps you to identify whether or not the person has lymphedema or lipedema, okay? Whether you can pinch or not pinch. And that should have given you a huge clue. I like to give like little clues, like on Jeopardy, they always give little clues here. So first thing is this a pressure ulcer? No. Okay, that's why I kept in the Stemmer sign there for you as a little clue. That's the forefoot of the foot. That would be a really unusual place for somebody to have a pressure ulcer. You don't really have a bony prominence there. And this was actually a peripheral vascular ulcer. Would you be coding that on the pressure ulcer section? The answer is no. No, and you don't stage it. Okay, how would you stage this wound? Stage 1, 2, 3, 4, DTI, or unstageable? Now, of course, if you were live with this patient, you would want to pull back that wound margin there so you could see a little bit better what's going on over here, for example. I know you wanted to do that. You wanted to pull that back. You wanted to do a little exploration there. So is this a pressure ulcer or is this not a pressure ulcer? By the way, those of you who are astute are taking a look at the dressing that was removed with the amount of drainage and what's going on here. So this was a pressure ulcer. This was stage 4. It was down into muscle, tendon, and bone. And that's why I was giving you that little clue that you would want to pull back and explore that area that was very, very deep over here in this area. Okay, what about this wound here? Stage 1, stage 2, stage 3, stage 4, DTI, or unstageable. And in case you don't know where the wound is, if it's hard to see, it's right there. So the first question always is this a pressure ulcer? Is this a usual place that somebody would get a pressure ulcer? It's not a usual place. Can you get a pressure ulcer there? I mean, if somebody's leg was hitting the side of the wheelchair constantly, yeah, they could get a pressure ulcer. But this is an unusual place. And remember I told you the hematogen staining, that dark discoloration? This is a classic venous ulcer. Do you stage this using the staging system? No. You do not use the staging category on that. Okay, what about this? This is on the leg between the knee and the ankle. Stage 1, 2, 3, 4, DTI, unstageable due to eschar. Okay, this one is a little bit hard, and that's because it's difficult to know what you're looking at, okay? And many times I would tell you that ulcers that present as this are misdiagnosed. I can't tell you the percentage of these that are misdiagnosed because nobody counts them, okay? But what you were looking at was a basal cell carcinoma. And this was somebody who was treated as a venous ulcer for years, and it was not responding. And remember, if a wound is treated for 30 days and it's not getting better, biopsy it to make sure that you're not treating a carcinoma. So it's not a pressure ulcer, you don't stage it. Okay, what about this? Stage 1, 2, 3, 4, DTI, or unstageable. This is on the trochanter, if you want to know the body part. The person was laying on their side. So is it a pressure ulcer or not is your first. And then if it is, you're going to stage it, right? So this is a pressure ulcer. It was a stage 4 because that white stuff in the middle, you could palpate down to the bone. Okay, how should you stage this wound? Stage 1, 2, 3, 4, DTI, unstageable, eschar. So once again, we want to know what we're looking at. And this is a pressure ulcer. It was staged as a 3 because of the slough that is there. Remember, any slough, 3 or higher. Okay, what about this wound? Stage 1, 2, 3, 4, DTI, unstageable eschar. So pressure ulcer, unstageable is the best answer here. Now, when I look at this, I say to myself, there's probably a backstory here in terms of what was going on with this person. So whether this started out as a pressure ulcer or whether this was a moisture-associated skin damage that converted to a pressure ulcer, I don't know because the person didn't arrive for care at the point where I knew the back history. Okay, so hopefully I have given you at least one new thought about how to differentiate pressure ulcers from other skin injuries and convinced you of how important that is. I've described in great detail one characteristic of pressure ulcers, which is staging, and that I have helped to enlighten you about comparing the NPUAP definitions as compared to CMS definitions so that when you hear about coding for EarthPi, you'll remember that you need to use the CMS definitions. And according to my clock, we have a few minutes for questions, and I know some questions have come in, so I will go to the ones that they've actually printed out for me first. And if I misunderstand your question, I'm going to apologize now. And if I don't get to your question, I'm going to apologize now, because I don't know how many questions have come in during my 2-hour talk. But I know that you can submit questions, and I'm sure CMS will give you one more time the website to submit questions later on and in the future that you might have so that you can get it clarified. So thank you for those of you who did send them in. So here's a question that came in this morning on the first half of the presentation. Maybe I answered it, maybe it didn't. But the question was, were you meaning to say a blister must be opened? And hopefully in the second half, after lunch, I made it clear that the blister could be intact or it could be open and ruptured, okay, in terms of determining it. But the most important thing is determining whether there are signs of deep tissue injury around that blister or not, in terms of staging it so that you can put it on the right part of the earth pie coating instrument. Here's another question which arrived earlier, which is another great question. When the slough comes off and now the wound is pink or red, may people call it stage 2? By definition, if it had slough, it must be stage 3 or more. Please comment. Thank you for the opportunity to say one more time. Any slough, any eschar in a pressure ulcer is at minimally a stage 3 or a stage 4. And once the slough, I'm going to extend the question, which is not written here from the person who asked the question. But the next part that I'm typically asked is, once the slough has been debrided and is gone, do I now stage this as a 2 because the slough is gone? And the answer is no. You are a healing 3 if you staged it originally as a 3. It is a healing 3 until you get to healed. Very excellent question. So I don't know, I think there's time for maybe one more question. Oh, okay. The rest of the questions are going to be answered during the Q&A. So thank you very much for those who submitted, and thank you for your attention. And again, CMS, thank you for giving me the opportunity to review the highlights of pressure ulcer staging.
Thank you very much, Elizabeth. All right, next we're going to have a presentation on the new pressure ulcer items in which we go over the coding aspects of these items. And I'd like to introduce my colleague, Caroline Gallagher, who I have taken the lead on the the IRF Quality Reporting Program here at CMS, and I've taken the reins from her. Caroline is an attorney and also a registered nurse, and she was responsible for standing up this program and has done a fabulous job. So I'd like to welcome her to the stage to present this.
Okay. Good afternoon, everybody. It's my pleasure to be here today just to introduce you. I don't know if you're familiar with the new IRF pie pressure ulcer items. If you haven't had a chance to take a look at them, we're going to go over them today so you can have a chance to get familiar with them before they get implemented on October 1st of this year. So you're going to need to become very familiar with them. So first of all, I want to tell you a little bit about this IRF pie and compare it to what you're using now. Of course, you know now on the IRF pie you're collecting pressure ulcer data, and there are, 3 questions, some multi-part questions. And do you feel that those questions are adequate to collect the pressure ulcer data? I mean, do you think it could be better? So we got a lot of people with comments, questions coming into our help desk, asking us how come we can't report stage 1 pressure ulcers. How come you're not collecting information about unstageable pressure ulcers? So we took a lot of the feedback into account, and we thought of ways to improve the pressure ulcer data items so that we could give you a way to report a lot more information to us and be able to give us a full picture of the pressure ulcers that you're assessing on your patients if they have any, and that you could tell us about the history of those pressure ulcers throughout the patient's stay. And so that's what this new pressure ulcer item set is. And after I explain it, hopefully if you're kind of confused by it now, it'll make a lot more sense to you. But this item set will allow you to document what a patient has on admission, and then at the end you'll be able to document exactly what happened to those pressure ulcers during the patient's stay. So let's start with talking about what you're going to be documenting on admission with the IRF for the pressure ulcer item set. Okay, so your admission assessment. Okay, the admission assessment for the pressure ulcer items, you're going to be documenting the presence of unhealed pressure ulcers on admission, which is item M0210. Do you notice a difference in the numbering from what you have now? Right now you have consecutive numbering. You have 48, 49, and 50, and there are like some ABCs in there. Now we changed just for the quality indicator section of the IRF we've changed to MDS type numbering system. Also used in the LTEC Care data set, which is a numbering system that goes by the system. So M is for the skin, the integumentary system, which is so we can add and change items, and if we need to add things, we don't have to change the numbering. It's a much more flexible numbering system. So if you're wondering why you're seeing these new numbers, that's why. You also, for patients with unhealed pressure ulcers on admission, you're going to document the number of each pressure ulcers at each stage. And also you're going to document your pressure ulcer risk conditions, such as if the patient has diabetes, if they have peripheral neuropathy, if they have a few other conditions that we have. And we'll go over those when we get to the end of the assessment. The admission assessment should be consistent with your clinical assessment. So technically you have a 3-day or 72-hour window to do your IRF assessment. But when the patient comes into your facility, do you wait 3 days to do your initial assessment of the patient, your physical assessment? You wouldn't want to do that. So there sometimes comes a bit of a disconnect, whether if a patient comes in and doesn't have a pressure ulcer, but on day 3, they might have developed a pressure ulcer. We've gotten this question, what do we do? Do we document what we saw in the patient on day 1, or do we document on the day 3 when we're filling out our IRF? And what we advise you is that the 3-day observation period is not intended to replace the time frame that for you to do your clinical assessment, and that you should document for your pressure ulcer assessment, admission assessment, what you found on your initial clinical assessment, not what what the patient's condition is on day 3, if that's when you do your documentation on your IRF. However, you should always follow your state and federal guidelines as far as your documentation. We never want you to not follow any state rules or guidelines or practices that you have for your practice acts in your state. Okay, now, item M210, unhealed pressure ulcers. This is kind of a gateway question to the item set. And this just simply asks, does the patient have 1 or more unhealed pressure ulcers at admission, a stage 1 or higher? And if the question, if there's none, then you can simply skip the rest of the item set and go on to the next set of questions. If the patient does have some unhealed pressure ulcers, then you would continue to the next item in the pressure ulcer item set. Okay, and that would be M0300A to 0300G, and we're just going to go over those real quick. Okay, so M0300A1, and that's stage 1 pressure ulcers. Stage 1, as Elizabeth, she gave you a great lecture. You're now all pressure ulcer coding experts, right? It's going to take some time and practice, as she said, and as she said, stage 1 is one of the hardest pressure ulcers to stage. Initially, we did not use stage 1 in the measure or on the IRF, but we believe that it's important to stage all of the pressure ulcers, and that information is very important that will help us to have that information, as well as you to do a well-rounded pressure ulcer assessment. So in the IRF, we included all stages of pressure ulcers. We felt that it was important, and we got a lot of feedback from IRF providers. Why can't I document information about stage 1 pressure ulcers? We want to be able to document that. So we did add stage 1 to the assessment. So in this item, you're going to just document the number of stage 1 pressure ulcers that are present on admission. If there are some, you would document the number, and if there are none, you would just document 0. The next item is the number of stage 2 pressure ulcers that are present on admission. And if there are none, you would just put a 0. And if there are 1 or more, you would just document the number of stage 2 pressure ulcers noted on admission. You would not document location or the size or anything like that. It's just simply the number of pressure ulcers present at stage 2. And the next item, M0300C1, is the number of stage 3 pressure ulcers present. And again, that's just simply documenting the number of stage 3s present on admission. And if there is none, you put 0. The next item in this item set, M0300D1, and that would be your stage 4 pressure ulcers. And again, it's just a number. And if there's none, 0. And next, we're going to get into our unstageable pressure ulcers. And as Elizabeth Aiello mentioned earlier, we do have a little bit of a difference between what the NP-UAP guidelines are and what we have done with the unstageable pressure ulcers. So I'm going to be telling you a little bit how we've divided out the unstageables in this item set. So the first category of unstageables that we have is 300E1, and that is unstageable pressure ulcers due to non-removable dressing or device. And you would enter the number of unstageable pressure ulcers in this category here in this item, if there's any. And if there's not, you just put a 0. And the next category of unstageable pressure ulcers that we have is the number of unstageable pressure ulcers due to slough or eschar. And if the patient has any, you would enter the number. If they don't, you would simply enter 0 here. See, the admission assessment should be fairly easy and should go quick, unless you have a patient with a gazillion pressure ulcers. And M0300G1, number of unstageable pressure ulcers. Well, we consider this suspected deep tissue injury and evolution as a category of unstageable pressure ulcers. And as Elizabeth told you, that is not one of the categories that the NP-UAP uses, but we have included this as a category of unstageable pressure ulcers. And for this item, you would just, if they do have any unstageable pressure ulcers, as we call it, or suspected deep tissue injury and evolution, you would document the number here. Okay, and that's it. I think when I said that it would be quick and easy to do your assessment, I don't mean that assessing your patient would be quick and easy. I meant that filling out this should be fairly easy once you have your information and your assessments done. I don't mean to say that assessing your patient and staging pressure ulcers is quick and easy. You should always do a good and thorough job and get good, thorough information. All right, now let's move on to the discharge assessment. The discharge pressure assessment, pressure ulcer assessment, you're going to, again, document the presence of unhealed pressure ulcers at discharge. Whether this is the same or different is what we want to find out. For patients with unhealed pressure ulcers at discharge, that's going to be documented in item M0210. And you're going to document the number of unhealed pressure ulcers at each stage. And you're going to look at the number of pressure ulcers that were present on admission and the number of pressure ulcers that are new or worsened during the IRF stay. And this, for patients with unhealed pressure ulcers, this is also going to look at the number of stageable pressure ulcers at discharge that were stageable on admission, were unstageable on admission, and the number of unstageable pressure ulcers at discharge that were stageable at admission, and the number of healed pressure ulcers at discharge. All right. When unhealed pressure ulcers are reported at discharge, follow-up items must be answered regarding the pressure ulcer evolution during the IRF stay. And for example, if M0300 C1 stage 3 follow-up items, here, let me just show you. Okay, here we go. We'll start with the first item on the discharge assessment is, again, your gateway question. Does the patient have one or more unhealed pressure ulcers at discharge? If the answer is yes, you're going to fill in the number of unhealed discharge, the same thing that you did with your admission assessment. How many unhealed pressure ulcers does the patient have when they are being discharged? And that would be compared to the number they had when they were admitted. If they had 0, then you put 0. Okay, and then the next of these items, they're similar to what you had when you were admitted, but they're going to be in much more detail, as you'll see. Okay, the first item is for stage 1 pressure ulcers. You're going to enter the number of stage 1 pressure ulcers that the patient has at discharge. Okay, if they have 1, you enter 1. If they have 3, you enter 3. Now, but this item is different from the one on admission because the next question, there's a series of questions under each item. So for M0300, you're going to have, of these stage 1 pressure ulcers present at discharge, you're going to enter the number that were present on admission as a stage 1 and remained at a stage 1 during the whole admission. So you would have, that's the first category of stage 1 pressure ulcers. The next category would be, of these stage 1 pressure ulcers, enter the number that were not present on admission, which would be new stage 1 pressure ulcers that have developed during your IRF stay. So for example, on your admission assessment, if you said the patient had 0 stage 1 pressure ulcers, on your discharge assessment, you said they had 2 stage 1 pressure ulcers, you should have on M0300 A3, you should have 2, because these would have developed during the IRF stay. Okay, and then for stage 2 pressure ulcers, for your first question, which is 300B1, you're going to enter the total number of stage 2 pressure ulcers that the patient has at discharge. If they had 1 or 0 or 5 or 2, you're going to enter that. For the second item, you're going to enter, of these stage 2 pressure ulcers present at discharge, you're going to enter the number that were present on admission and the number that remained at stage 2 at discharge. So these are going to be the ones that the patient had stage 2 at admission and you documented, and the ones that when they were discharged, they were still there at stage 2. Okay, and the next item in that set is, of these stage 2 pressure ulcers present on discharge, you're going to enter the number of these ulcers that were present on admission as an unstageable pressure ulcer due to the presence of a non-movable device, or that's a dressing or device. and when it became unstageable, the pressure ulcer was staged as a stage 2 and remained at a stage 2 at the time of discharge. Does that make sense? Okay, so this is when the patient came in, they had a stage 2 admission. It was, when they came in, it was an unstageable, but then it became stageable and it was a stage 2. And it remained a stage 2 until the patient was discharged. Does that make sense? So this gives you a way to track those unstageable pressure ulcers. You're going to know that when a patient comes in and you document an unstageable pressure ulcer, you're going to have a way to document what happened to it when the patient was discharged. I'm going to get my drink real quick. My mouth is real dry. I'm sorry, I should have brought this up with me when I'm talking makes my mouth. Okay, sorry about that. Oh, that's better. Okay, so let's go to the next one. All right, of the stage 2 pressure ulcers reported in M0300B1, you're going to put the number that were unstageable on admission due to the non-removable device dressing that became stage 2 and then remained stage 2 until discharge. Everybody's got that right? Okay. Let's go to the next one. All right, and then there's another category in the stage 2 discharge assessment. Of these stage 2 pressure ulcers present at discharge, enter the number that were not present on admission or were at a lesser stage and then became stage 2. So you're going to have a patient that when they came in, they did not have an ulcer and they developed an ulcer. It was a stage 2 when they were discharged, or they had a stage 1 when they were admitted and it became a stage 2 and it stayed a stage 2 till they were discharged. Does that make sense? Okay, so it gives you a way to track. That would be the first category, not present on admission, would be a new pressure ulcer, and the B category were at a lesser stage at admission and worsened to a stage 2. What would that be? That would be a worsened pressure ulcer because it was at a lesser stage and worsened to a stage 2. All right. Number stage 3 pressure ulcers. And this is the same kind of thing, but now you're tracking stage 3. Okay, in the first category, you're going to enter the total number of stage 3 that the patient has at discharge, which may be 0, it may be 1, it may be more. And then the next category is of these stage 3 pressure ulcers present at discharge, enter the number that were present on admission and remained at stage 3 at discharge. That one's pretty easy. Of these, and the second one is of these stage 3 pressure ulcers present at discharge, you're going to enter the number that were present on admission as an unstageable pressure ulcer, and that could be of any type, on any of the 3 categories. And when it became stageable, it was staged as a stage 3, or it remained a stage 3, and it remained a stage 3 until the time of discharge. Okay? So the stage 3 pressure ulcer was present at discharge, and it was present at admission when the patient came in. So they were admitted with stage 3, but it was unstageable when they were admitted. And you couldn't stage it, but you didn't know what stage it was. But then when you could stage it, it was a stage 3, and it remained a stage 3 till the patient was discharged. Everybody got that? All right, and then the next category under stage 3 and is of these stage 3 pressure ulcers present at discharge, you would enter the number that were not present on admission or were at a lesser stage at admission and worsened to a stage 3 during the IRF stay, or were unstageable on admission are due to a non-removable device or dressing, it should be dressing too, at admission and initially became stageable at a lesser stage and then progressed to stage 3 by the time of discharge. Okay? So this pressure ulcer was not present on admission or was at a lesser stage and worsened to a stage 3. So there's three different ways it could happen here for this item. You would have a stage 3 that wasn't present on admission, and then you develop a stage 3 during admission, which would be a new pressure ulcer. The second thing is you could have a pressure ulcer that was present. It would say it could have been a stage 1 on admission or a stage 2 on admission, and then it worsened to a stage 3 and remained a stage 3 until the patient was discharged. Or the third category was the patient had an unstageable pressure ulcer due to a non-removable dressing or device at admission, and then it became stageable at a stage 3, and it remained at stage 3 until the patient was discharged. And as Elizabeth said, when you have a stageable pressure ulcer and it becomes stageable, that is not worsening. Okay. All right. And you would enter if you have none of those if you meet none of those criteria, you would just enter 0 for that item. All right, stage 4. I'm just going to go through this real quick. This is kind of really is a repeat of the same thing. Of these stage 4 pressure ulcers, you're going to report the number of stage 4 pressure ulcers at discharge that were present on admission at stage 4 and remained at stage 4 at discharge. You're going to report the number of stage 4 pressure ulcers that were present on admission as an unstageable pressure ulcer, and when it became stageable, it was at a stage 4 and it remained a stage 4 until the patient was discharged. And of these stage 4 pressure ulcers at discharge, you would report the number that were not present on admission or were at a lesser stage on admission and worsened to a stage 4 by discharge, or were unstageable on admission initially and became stageable at a lesser stage and then progressed to a stage 4 by discharge. And if you have none of those, of course, you enter 0. Okay. And then now we'll get into the unstageables real quick. M0300E1 is your unstageable pressure ulcers due to a non-movable dressing or device. If the patient has none of those, you would just put a 0. If they have more than one or more, you enter the number. The second category under that, the unstageable due to a non-movable dressing or device, is that if the patient has had this type of unstageable pressure ulcer, it was present on admission as an unstageable pressure ulcer due to a non-movable dressing or device, and it remained unstageable due to the non-movable dressing or device until discharge. You would document it there. The next category is of these unstageable pressure ulcers due to a non-movable dressing or device at discharge, if it was present on admission and it became stageable. If it became, it was, sorry, let me back up. Okay, you would document the number that was present on admission as an unstageable pressure ulcer due to a non-removable dressing or device and remained unstageable during the IRF stay. All right. All right, this is the second category of unstageable pressure ulcers. It's basically the same thing. You're just going to document the number that were present on admission, remained there until discharge. Then you're going to, the second category is the present on admission and remained unstageable. Or it was present as a stageable pressure ulcer, then became unstageable and remained unstageable until discharge. And then you have, as we categorize the suspected deep tissue injury and evolution as an unstageable pressure ulcer. And the same category is going to apply to this one. You're going to have the, you're going to document under M0300G2, you're going to document the number of these pressure ulcers that were present on admission as an unstageable pressure ulcer due to suspected deep tissue injury and remained unstageable until discharge. And M0900 is the healed pressure ulcers at discharge, which is not something we collect on admission. That's something that's not there. And this is just, if you've healed any pressure ulcers during the IRF stay, you would enter the number of each stage of healed pressure ulcers. Stage 1, 2, 3, and 4. And if there's no, if there are no healed pressure ulcers during the stay, you just enter 0 for each of the items, or any items that you do not have any healed pressure ulcers. Okay. And just a few other things I'll tell you. If a pressure ulcer is unstageable on admission and becomes stageable during the IRF stay, and then heals by discharge, that you would code it under that item, but you would have to make sure that it's completely healed, completely epithelialized, and you know, it has to meet the definition of a healed pressure ulcer. It couldn't be, couldn't have any open areas. All right, the last item is the pressure ulcer risk conditions. These are the items that we use for risk adjustment on the pressure ulcer measure, and so we need this information to help us with risk adjustment for purposes. So basically what you would need to do is just check off. We don't need ICD codes. We don't need you to give us any information, but other than just say yes or no by putting the number of the answer that you are going to give us. Peripheral vascular disease, peripheral arterial disease, diabetes mellitus, diabetic retinopathy, diabetic neuropathy, and diabetic nephropathy. And if you'll notice for I-2900A, for diabetes, if the patient doesn't have diabetes, you can skip the rest of the things under diabetic conditions. There's a skip pattern there. Okay, and then one more thing is height and weight. It's another risk adjuster that we use for the pressure ulcer measure. You'll find it's not in the quality indicator section. It is in the what we call the payment section of the IRF PI. It's outside the quality indicator section in item 25A and 26A. In that section of the IRF PI, they're still using the consecutive numbering system, so that's why the numbers are different. But height would be measured on admission, and the weight also measured on admission, and that would be in inches and in pounds. And it's important that you do provide that information because that's a mandatory item, and if you do not provide that information, it could be grounds for noncompliance with your quality reporting requirements. Okay. This is information. What do you have to do to comply with the requirements of quality reporting? And can you put dashes in for any of the items? I know that's a big question we get a lot. Dashes can be used for pressure ulcer items if skin assessment has not been completed. But that would be in rare circumstances that would be acceptable. Say if the patient was admitted and then 12 hours later they got sent back to the ER for emergent purposes. We expect that you would not do that very often. If you do, we get IRF PIs from a particular provider and they constantly use dashes, then there's a pretty good chance they could be held in noncompliance with their reporting requirements, and that is that's 2% payment reduction associated with noncompliance. So you don't want to do that. patients discharged unexpectedly, and clinicians have not had a chance to do their discharge. Say they sign out AMA and you didn't know they were going to leave, and their family comes and takes them home, and you couldn't do the discharge assessment in time. That would be a grounds for using dashes for the discharge assessment, something like that. If a patient experiences an unplanned discharge and a full skin assessment was completed within 3 days prior to discharge, the assessment may be used to complete the discharge pressure ulcer items. If a full skin assessment has not been done within the 3 days prior to the discharge, then you can use the dashes. But you report the status of any known pressure ulcers that were assessed within 3 days prior to discharge. In normal cases, when you're doing a discharge, there's a 3-day window to do your admission assessment and a 3-day window to do your discharge assessment. But we ask that you try to do your discharge assessment and report the status of the patient, well, as close to discharge as possible. All right. There are some items on this new IRF that are voluntary, some that are mandatory. There is a table that is posted with the manual, the IRF training manual. Items that are mandatory are the items that are part of the quality measure and that are required: height, weight, the measure, the pressure ulcers, stage 2, 3, and 4 are mandatory. Stage 1 is not. So any items associated with stage 1. We encourage you to provide that information. If you look at this, I know I went through this fast, and not the most eloquent speaker, but if you look at this, you'll see that this assessment really makes sense, and if you add all this up, if you add like your first item of the assessment on discharge, you have your first item where you put the total number of pressure ulcers at each stage, and then there's the subcategories. It all should add up, and because with your first item at the top, the very first item, it says the number of unhealed pressure ulcers at discharge. All the things underneath should add up to that number, and it is actually a logical way to keep track of what happened on, from the admission to the discharge. And so we suggest, or strongly suggest that you do give it a try and try to provide the information, because it does help us to see what's going on with stage 1 pressure ulcers. And also unstageables are one of the voluntary items as well. Let's see, what do we got left here? Okay, I think, Charles, I'm done now. So we have a Q&A coming up. Thank you very much.
Thank you.
Thanks. Oh, sorry. My mouth was so dry, I couldn't hardly talk.
Thank you, Caroline. Okay, we're running a little ahead of time, so we're going to take a break here, and I'm going to ask that everybody be back here at 2:30. Unfortunately, I can't speed things up since we're streaming this via the web, and we have an agenda out there with specified times for presentations. So I'm going to ask that we take a break now, be back here at 2:30. We will answer some questions. Again, if you're attending via web stream, we're encouraging you to submit questions through our IRF help desk, which is irf.questions@cms.hhs.gov. And those of you here have been submitting questions, some of you more than others. But we will address some of those questions coming up at 2:30, and then we will have the CDC presentation on the influenza vaccination, healthcare personnel vaccination measure at 2:45. All right, thank you. All right, welcome back. We're going to get started on some answering some questions here. We've had several submitted, and I'm going to go ahead and let Elizabeth go first with some of the pressure ulcer questions.
Great. Thank you, Charles. What I'm going to do is I'm going to group the questions into what I call themes, but I'll read each of the individual questions so you get a sense of what people ask. So the first one had to do with who can stage, and I'll read you the exact questions as they were asked. Do you recommend that RNs do not stage pressure ulcers and deter to MD and or a wound ostomy incontinence nurse? And the other themed question, which I think is the same idea, is when you refer to state licensing laws, are you saying that all staging is part of the medical diagnosis and must be officially staged by doctor, or, and I'm not sure if this says, what do you think that says?
I think it says NP.
NP, okay. Or only certain conditions related to pressure ulcers. We state this because each state has its own licensing requirements and regulations surrounding who may or may not assess a patient. Okay, so first of all, when I made the comment about making a medical diagnosis, I was not referring to pressure ulcers. I was referring to venous ulcers, arterial ulcers, for example, because remember, a battery of tests need to be taken that the average staff nurse cannot prescribe to do. So I'm sorry if I didn't make that clear in terms of who does and declares a venous ulcer, an arterial ulcer, for example. So people who are licensed in your state to make medical diagnosis, physicians, nurse practitioners, physical, in some states it's even physical therapists can do this, physician's assistants, in terms of that. In terms of staging of pressure ulcers, which I think is part of what this question asks, okay? The American Nurses Association, if you go to Google, the source of all answers for questions nowadays, Becky Patton, who was the president of ANA at the time, actually has issued a position statement from the American Nurses Association saying that it is within the scope of nursing practice for nurses to stage pressure ulcers. Now, I am not an expert in the Nursing License Act in all 50 states. If you are in a state that for some reason would have something in it that says that a nurse could not stage, obviously, and I'm talking about the staff nurse at this time, then you need to refer to that within your particular state. But right now, nurses, and I'm talking generalist nurses, can stage pressure ulcers. Now, the second correlate that wasn't asked is what about LPNs? And again, you need to look at the licensure in your state if on your rehab setting you have an LPN, because the word assessment is tricky in Practice Act. So when I say nurse, I'm referring to a licensed registered professional nurse, RN. So hopefully I've answered that question. The next one that had to do with pressure ulcers related to medical devices. And there's two questions that I think coincide together. One says pressure ulcers related to indwelling Foley would be mucosal and not staged. And the other one is, why is an ulcer from a nasal cannula not pressure? So two different body parts that have to do with medical devices. And again, I want to make this very clear. The answer is it depends where the pressure ulcer injury has occurred. And this may sound like splitting hairs, but if the skin damage from the medical device is on mucosa, so let's say you had a nasal cannula with the prongs into the mucosa, into the nose, where you had mucosa. If the damage is in the mucosa, that doesn't get staged because mucosa is not the same as skin. If the damage was here on the cheek, which is skin, then you could stage it as a pressure ulcer. Same thing on the other end of the body. If you had a urinary indwelling catheter, which we all use the brand name Foley for, if the damage is internally within the urinary meatus, which is mucosa, you can't stage that as a pressure ulcer. But if the damage was, let's say, from the tubing over the thigh on the skin, that you could stage as a pressure ulcer. So the question is, you need to always know where the pressure ulcer is. Is it on mucosa or is it on skin? So I got those. Let's see. And these are great questions, by the way, that you submitted to me. And some of them we're going to, Caroline and myself are going to both co-answer because they kind of overlap. Okay. Before I answer the next question, I want to say that whenever there's a change in coding, and CMS can say whatever they would like to say, it gives you an opportunity to look at how you're documenting the clinical characteristics, in this case of wounds, very specifically in terms of pressure ulcers, so that the clinical people are doing the documentation. So that then, and obviously much more is required than what we're talking about just here in staging for the clinical care and identification of a pressure ulcer, for example. Remember, this is really only talking about staging here. So you need to look at your capturing of documentation and how you communicate that information from clinical people who might be then filling out the forms for CMS. So I think it gives you an opportunity to look at how you communicate clinical information within your IRF setting. So with that, let me answer this question. If the nurse identifies a stage 1 pressure ulcer during the admission assessment, but then the skin nurse documents the same wound as a stage 2 the following day, what do we code it on IRF? So I'm going to answer it from the clinical point of view, and then I'm going to ask Caroline from a CMS point of view to answer it. And that's why I said capturing your clinical information is really very important. And when you have a difference amongst clinical people looking at what the wound is, in this case it's the stage of the pressure ulcer, but it could have just as well been somebody not labeling it a pressure ulcer when it should be a pressure ulcer or vice versa. So we'll put in the higher category of discrepancies of identification here of the etiology of the wound and or staging if it's a pressure ulcer. You need to resolve those conflicts within your facility and have some kind of a policy as to how you do that. And I would suspect that CMS can tell you their opinion, but this is also a teaching opportunity in terms of the generalist versus the wound care specialist. And as I have said many times, there's a lot to know about how to identify skin injuries and stages. So don't fight in the chart, but this is where you need to huddle together and come together and take a look. But ultimately, somebody is going to pick something from the person's chart and then put it on the coding forms for CMS. So Caroline, do you want to add anything on that?
Yes, we've actually had this question come up several times in our help desk emails, and what our policy is that we would encourage each facility to resolve this issue based on your facility's policies, practices, and procedures, or the regulations in your state, because of course, there's IRFs in all different states, and there may be different state laws that apply. So we don't want to make a policy that might not be applicable to, or be in conflict with different state laws. But I do agree with what Elizabeth has said, and that is something that should be decided among the healthcare team. And it would be something that normally somebody with the specialization in that area they should be deferred to, but we don't really make a policy about that. Another thing I want to say about that is that as far as the IRF documentation and as far as the documentations you find in the chart, the IRF is not going to document everything, and it's not meant to take the place of your medical record. And so you may document, and we don't always use, 100% follow the NPUAP guidelines. But that doesn't mean that your facility, you can't in your medical records document what you need to document. So we encourage you to do what you need to do and follow your guidelines.
this is going to be a conversation between clinician and CMS, which I think is great. The next question here, do you score, and I'm not sure if you meant staging or coding here, a pressure ulcer noted on day 4, but then resolved prior to discharge? And then the second part of that is, if ulcer stage 3 on day 4 and stage 2 on discharge, how to stage this? Okay, I'm going to say this one more time. You do not reverse stage. If the pressure ulcer was stage 3, it's never going down to stage 2, whether it's on discharge or at any other part on there. You do not reverse stage. It would be a healing stage 3 throughout the person's admission and time in the inpatient rehab setting. In terms of coding, I'm going to let CMS answer that in terms of their guidance to tell you what to do about coding.
Okay. All right. Okay, so if there was a pressure ulcer that was noted on day 4, but then it was resolved prior to discharge, if resolved means that it was completely healed and now is completely epithelialized before the patient was discharged, then for coding purposes, when the patient, on the admission assessment, you would document the pressure ulcer at the stage it was at when the patient was admitted. And then on the discharge assessment, you, if the pressure ulcer, there's 2 ways you could code this. If the patient at discharge has no other pressure ulcers, on the M0210, which is that gateway question that asks, does the patient have 1 or more unhealed pressure ulcers? You are not going to include that pressure ulcer in there. So if the patient has no other pressure ulcers, you're going to answer 0, because if that pressure ulcer is completely healed and totally resolved, and that's pretty high standard to meet when you're healing pressure ulcers, because they have to be completely epithelialized. And if that's the case, and the patient has no other pressure ulcers, you could put 0 for the, that gateway question, M0210. And then you would go to the healed pressure ulcer question on discharge, which is M0900, and you could put, let's assume it's a stage 3 on admission, the number of healed pressure ulcers, and again, assuming there were no other pressure ulcers at admission or discharge, you could enter for healed pressure ulcers under M0900C, which is stage 3, you would enter 1. Now, I do want to point out that the definition under this is indicate the number of pressure ulcers that were present on admission and have completely closed, resurfaced with epithelium upon discharge. CMS is issuing guidance right now, and we can issue it, formal guidance, is that this is going to include pressure ulcers that develop after discharge as well. It's not only going to be pressure ulcers that are present on admission.
Thanks, Caroline. Appreciate it. All right, that's all the time we have for questions right now. We will have a last question and answer session in the day, at the end of the day. And those questions that don't get answered today, we will be compiling these questions and responding with the frequently asked questions document. And sharing those questions with everybody. So if your question didn't get answered today, by the end of the day, don't worry, we will definitely respond to it and get everybody those answers. We'll share them with everybody. Thanks. All right, actually, I gotta grab one thing. One second. Okay, next is going to be our presentation on influenza vaccination coverage among healthcare personnel. And today we have with us, actually she's not here, but she's going to be giving this presentation remotely from the CDC. We have Megan Lindley, and Megan is the Deputy Associate Director for Science in the Immunization Services Division at the CDC. and she is the lead subject expert for healthcare personnel influenza vaccination reporting through the NHSN, which is how this particular measure will be reported by IRFs. So I'm going to turn it over to Megan, and I will advance the slides for her as we move through this presentation.
Okay, can you hear me?
I sure can.
Excellent. So can you advance it to the third slide, I think it is, that has the denominator statement in the title?
Uh-huh.
Excellent. The live stream is a little behind, so I'm just going to follow the slides. So as Charles mentioned, I'm going to speak to you a little bit today about reporting influenza vaccination coverage among healthcare personnel. CDC has our NHSN measure divided into the denominator statement, which is basically who you need to measure it among. And then the next slide, I'll show you the numerator statement, which has the measurement categories. So for this denominator statement, the measurement of vaccination is among the healthcare personnel that are working in the IRF for at least 1 day from October 1st through March 31st of the following year. And that's regardless of clinical responsibilities or patient contact. That's everybody working in the facility or unit. And then we have 3 categories of required healthcare personnel in the denominator, and that's employees, licensed independent practitioners, and adult students, trainees, and volunteers. So employees are basically everybody working in the IRF who receives a direct paycheck from the reporting facility, so your payroll. The second group, licensed independent practitioners, is limited to 3 kinds of practitioners. It's physicians, advanced practice nurses, and physician assistants only. And those would be folks who are affiliated with the IRF but who do not receive a direct paycheck from the reporting facility. So usually that could be somebody whose relationship with the facility is through a contract, or it could be somebody from another institution that's rounding on a patient or visiting a patient for some reason. And the final category is fairly self-explanatory: adult students, trainees, and volunteers. Adults 18 years of age or older who are in there as healthcare professional students, residents, or interns, or volunteers, again, who do not receive a direct paycheck from the reporting facility. And again, all of those categories are regardless of patient contact. Next slide.
Okay.
So this is our numerator statement for the healthcare personnel measure. So every healthcare worker in the denominator who from October 1st or when the vaccine comes available through March 31st of the following year either receives a vaccination at the healthcare facility or reports in writing that the vaccine was received elsewhere, or was determined to have a medical contraindication of a severe allergic reaction to eggs or another vaccine component, or a history of Guillain-Barré syndrome following a previous influenza vaccination, or who declined influenza vaccination, or whose vaccination status was unknown, or who doesn't meet any of those other categories. And I'll go over those in a little more detail. So the first thing I want to point out, because it can be confusing, is that the numerator time period is slightly different than the denominator. As you saw in the previous slide, the denominator begins October 1st every year. But the numerator can begin prior to October 1st, and that's because CDC recommends that influenza vaccination begin as soon in the season as possible. And so we don't want to penalize facilities who have a vaccination campaign starting in August or September. So that's the reason for that difference in language with the October 1st or when a vaccine becomes available. Another thing to note is when looking at vaccination outside of your facility, the reported in writing or provided documentation can be a form that you ask somebody to complete. It could be a note from their outside doctor or a receipt from Walgreens, or it could be as simple as them putting in writing to whoever is doing this tracking an email that says, I received the vaccine at this place. But if they are vaccinated outside the facility, they do need to provide some kind of written documentation. The other thing to note on the numerator statement is with regard to medical contraindications. In order to keep the reporting consistent across facilities, we've identified those 2 very specific categories of medical contraindication, which is severe allergic or hypersensitivity reaction to a vaccine component, or a history of Guillain-Barré syndrome within 6 weeks of prior influenza vaccination. We're not asking you to change your policies, but we are asking if a healthcare worker is granted an exemption for any medical reason that does not meet one of those two criteria, that for NHSN reporting purposes, they should be reported as declined vaccination. And that would be the same for employees, for healthcare personnel that receive, for example, a religious or philosophical exemption to immunization. They would be counted as declined immunization. Next slide, please.
Okay.
So this is just a shot so you can see this is actually the paper version of the reporting form, but it's very similar to the screen you will see in NHSN for IRF healthcare personnel influenza vaccination reporting. You see those required categories across the top, the employees, the licensed independent practitioners, and the adult students, trainees, and volunteers. That other contract personnel category at the end is optional. You don't need to worry about that if you don't want to. And then the rows in the form, the first row is your denominator statement, the number of healthcare personnel who worked at the IRF or IRF unit. And then 2 through 6 are those numerator categories that I discussed on the previous slide. And you can see that vaccination at the facility and vaccination outside the facility with documentation are reported separately in NHSN. And it's important to note that those rows 2 through 6 need to add up to row 1. So everybody that's in your denominator needs to be accounted for in one of those numerator categories, even if it's I don't know, which is the last category. Next slide, please. So the next slide, the IRF final rule that CMS issued last year for influenza vaccination coverage among healthcare personnel, and that's the NQF measure 0431. The use of this measure is going to begin October 1st of this year, and the reporting is set to affect the fiscal 2016 annual payment update. Each IRF is going to be required to collect data about healthcare personnel that do or do not receive influenza vaccination during the season. And as I noted before, this measure defines the influenza season as October 1st through March 31st of the following year. Next slide.
Okay.
So as I mentioned on the denominator slide, healthcare personnel who've worked 1 or more days in the IRF or IRF unit should be counted in the measure denominator. This next part is a little bit complicated. Beginning with this influenza season, the 2014-2015 season, so October 1st, 2014 through March 31st of next year. If you have a unit that is part of an acute care hospital, you may have heard different guidance for reporting before, but beginning next year, inpatient and outpatient units of the same acute care hospital that do not have separate CMS certification numbers or CCNs are going to be reported on a single data entry screen in NHSN for that hospital. However, there are some caveats that pertain to IRFs that I'm going to discuss in the next slides. So next slide, please.
Okay.
So the next part of that guidance is that healthcare personnel working on patient care units within the acute care hospital that do have a separate CCN, even if the CCN is different only by a letter in the third position of the CCN, should not be included in the acute care hospital summary totals unless they also work in a unit of the acute care hospital during that October 1st through March 31st time period. Next slide, please.
Okay.
So this slide is just a list of the types of facilities that this guidance will probably apply to, and you can see that IRFs are the first example. Also inpatient psychiatric facilities, skilled nursing, long-term acute care, ambulatory surgery, and outpatient dialysis facilities. And that link is to some CMS guidance about CCNs. So the takeaway is if you're part of an acute care facility that has been reporting influenza vaccination data already, the facility may have received guidance to include IRF healthcare personnel in with the acute care hospital, and that was accurate. However, going forward, starting this October, it's no longer accurate. The IRF employees or the IRF healthcare personnel need to be reported separate from the acute care hospital. So that's really the takeaway of those slides. Next slide, please.
Okay.
So the data collection timeframes and the data submission, you're asked to submit a final report to NHSN by May 15th each year. We do strongly encourage facilities to update healthcare personnel influenza vaccination summary data on a monthly basis, because being able to examine that throughout the influenza season really gives you the information that you need to know about the level of protection among their healthcare personnel in your IRF, and if there are changes that you need to make in your vaccination program, for example. However, what's required by CMS is a single summary report of influenza vaccination that covers the entire influenza season, October 1st through March 31st, and that needs to be in NHSN by May 15th so that we can share it with CMS. And as you saw on the data reporting form, the vaccination data should be reported separately for those three required groups of healthcare personnel, which is employees, licensed independent practitioners, and adult students, trainees, and volunteers. And reporting data for other contract personnel is optional at this time. Some facilities like to use that for their own internal tracking, for Joint Commission accreditation, for example, but you can just leave it blank if you don't want to use it. For the required categories, you can't leave it blank. NHSN won't let you save the data if required data are blank. Next slide.
Okay.
So this is just a table that appeared in the CMS rule, I believe, which summarizes the previous slide. So for this first year of reporting, the data collection period is going to be October 1st, 2014 through March 31st, 2015. And the data submission deadline, as I said, is May 15th, 2015. And then for future reporting years, the data collection period will be October 1st through March 31st of the following year. And the data submission deadline will be May 15th of that year. Next slide.
Okay.
So this slide describes reporting IRF QRP data through NHSN. Some of you may already know NHSN is the current data submission mechanism for CAUDI data. So you might be familiar with it already, and now it's going to be the data submission mechanism for healthcare personnel influenza vaccination measurement for IRFs. If you need information on data collection and submission for the measures, you can visit the NHSN website, which is displayed in that URL. It's not on the slides, but I should also say that we are developing right now more detailed training on healthcare personnel influenza vaccination reporting for IRFs that will be made available at the end of this summer. So there'll be some more detailed information for you that's not up on the website right now. And if you're a freestanding IRF, you need to be enrolled in NHSN as an inpatient rehabilitation facility, a separate facility. If your IRF is a unit in an acute care or a critical access hospital, then it's the hospital that's enrolled in NHSN, but the IRF unit needs to be mapped as a rehab ward of that hospital. And if you are not yet enrolled or you don't think your unit is appropriately mapped or you have questions about your status in NHSN, you can email the NHSN help desk, which is nhsn@cdc.gov. And I've included a link to the NHSN website that has some frequently asked questions about the enrollment process. And just wanted to mention that there are some specific online training modules that you will need to complete prior to receiving reporting permissions from NHSN if you're not currently enrolled. Next slide.
Okay.
And we also provide what's called operational guidance, which is basically a brief summary of how facilities should report various quality measures in order to be in compliance with the CMS reporting rules as they relate to NHSN. So on this slide, I've included a link to the operational guidance for the IRF CAUDI data and a new operational guidance for the IRF healthcare personnel influenza vaccination data. And then that last bullet is just a reminder that if you have any questions about NHSN enrollment or about the measures that you're supposed to report through NHSN, or anything like that, you should feel free to email us at nhsn@cdc.gov, and we'll get your question answered as soon as possible. Next slide. So I guess that's all I had. I didn't know if you wanted to do questions on this now or if you have a designated question period
we're actually
for
taking
later.
written questions, Megan, and then some questions at the end of the day. So what I'll do, if there are some questions that we can't directly answer, I will certainly reach out to you and have you help in answering those questions, and then we will get back to everybody with answers to those.
Okay, sounds good.
Okay, so thank you very much for your time. Really appreciate it, and we'll see you soon.
All right, thanks.
Okay, take care. All right, great. I'd like to invite Ann Deutsch back up, and she is going to speak about the patient influenza items. So we're going to stick on the top of influenza, but switch from healthcare worker to the actual patient measure, and I will give it over to you.
Great. Okay, so as Charles said, this next section will focus on the new items related to the quality measure percent of patients or residents who are assessed and appropriately given the seasonal influenza vaccination. So over the next 20 minutes or so, I'm going to describe the quality measure, and then I will go back and talk about the items that are filled out. So hopefully that will kind of link up how the measure is calculated. So the quality measure in this case is a percent value. So there is a denominator, so the patients who are included in the measure, and then the numerator is basically the subgroup or subset of patients who, out of the denominator, meet the numerator criteria. So the denominator is where I'm going to start because that's the most important place to get started, who could be potentially included in the measure. So the denominator is all patients aged 6 months and older with a target assessment, so an IRF during the denominator time window. Patient refusal and ineligibility are included in both the numerator and denominator, and you'll see how that's captured in just a minute. So basically, anybody 6 months and older would be included. The IRF as we mentioned earlier today, is filled out on Medicare patients, both fee-for-service and Medicare managed care. So you may not have anybody, or may not have too many patients in the younger age group, but again, anybody 6 months and older would be included in the denominator. So the exclusions are patients who were not in the facility during the denominator time window. So that means an admission date after March 31st and a discharge date before October 1st. And we'll go through some examples as the presentation moves along. So now you know who's in the denominator. Now we're going to talk about the numerator. So patients who are in the numerator include those patients who were also in the denominator who received the influenza vaccine during the most recent influenza vaccination season, either in the facility or outside of your facility. 2, individuals who were offered but declined the influenza vaccine. And then 3rd, individuals who were ineligible due to contraindications, and contraindications would include things like the person having a severe allergic reaction to the influenza vaccine in the past, a patient who has a history of Guillain-Barré syndrome within 6 weeks after a previous influenza vaccine, or somebody who had a bone marrow transplant within the last 6 months. Each numerator criterion will be computed and reported separately. So the influenza vaccine season is defined by our colleagues at CDC. So for the 2014 to 2015 influenza season, the influenza vaccination season is defined as beginning October 1, 2014, or when the influenza vaccine becomes available, whichever is first, through March 31st, 2015. For the following year, 2015 to 2016, the influenza vaccination season is defined as beginning October 1, 2015, or when the vaccine becomes available through March 31st, 2016. And then for subsequent influenza seasons, the influenza vaccination season is defined as beginning October 1 or when the vaccine becomes available through March 31st. So for the individual who is filling out the IRF-PI, so this would be perhaps a discharge when you're filling it out, these are some steps that you would take in order to complete the IRF-PI assessment. Obviously, within your facility, you will set up procedures in order to find out if the patient received a vaccine, perhaps in an acute care setting, if the person was in acute care prior to the inpatient rehabilitation stay. But this is just basically when you're ready to discharge a patient and filling out the IRF-PI. So to determine if the influenza vaccine was received for this year's influenza vaccination season, you would review the patient's medical record to determine if the vaccine was received in your facility. And when I say facility, consistent with what Megan mentioned in her previous presentation, your facility is your inpatient rehab facility. So it's not the medical center. If you are an inpatient rehab facility, it's whether the patient received the vaccination in your inpatient rehab facility. You would also review, when available, the patient's medical record from a previous setting. So obviously many of your patients may have been admitted from an acute care hospital, and so if you have information about the acute care stay, you would need to determine if the patient received the influenza vaccine during the acute care stay or perhaps at another location. You can ask a patient if they've received the vaccine outside of your inpatient rehab facility, and you can also ask another person affiliated with the patient, a responsible party, legal guardian, primary care physician. If vaccination status cannot be determined, refer to standards of clinical practice to determine whether or not to administer the vaccine. So the influenza vaccination items on the IRF-PI version 1.2 start off with item O0250A. And just in terms of the numbering, this numbering is consistent across some of the other settings, including, for example, the long-term care hospital data set where they have the same set of items. So the first item, O0250A, documents whether the influenza vaccine was received in this facility, so within your IRF, for this year's influenza vaccination season. You code yes if the vaccine was received in the IRF, and then you continue on to the next item, which will ask you to report the date. If you indicate the answer is no, then you would continue on to 00250C to indicate the reason why the patient did not receive it in your IRF. A code or a dash can be entered, which means that it cannot be determined. I would not expect that that would be used very often at all, because that would basically be meaning that the patient, it was unknown whether the person received the vaccination in your facility, and you would have a medication administration record that would document that in a standard way. So again, I would not expect you to have any dashes. The second item then is only filled out if the answer is yes to the first item, that there was a vaccine given to this patient in the IRF setting. So this second item documents the date that the influenza vaccine was received. So you would enter the date, and it only, again, applies if it was received in the IRF. If the vaccine was received outside of the IRF, you would be skipping over this item. In terms of filling out the item, do not leave any boxes blank, which means that you'd be required to complete an 8-character date. If the month contains a single digit, fill in the first box of the month with a 0. If the day contains only a single digit, then you would also put a 0 in the first box. So for example, October 1, 2014 would be entered at as 10/06/2014. For somebody who got the vaccine on January 7th, 2015, that would be entered as 01/07/2015. If the date is unknown or information is not available, a single dash needs to be entered in the first box. And again, I would not expect this to be used very often, if at all. So in the cases that the patient was not given the vaccination in your IRF, you would indicate why that was not done. And so this graphic shows you what exactly looks like on the IRF pie. You enter only one code. And just over the next couple of slides, we'll review the reasons. So you would code 1 if the patient was not in the facility during the influenza vaccination season. You would code 2 if the vaccine was received outside the facility. So that would include maybe the acute care hospital immediately prior to the IRF stay. You would code 3 if the patient was not eligible due to medical contraindications. And on my previous slide, I mentioned some of the examples, but there's a longer list here. It could include that the patient has a history of an allergic reaction to eggs or other vaccine components. The physician has an order not to immunize, so some of the reasons that I mentioned earlier, like Guillain-Barré, may be one of the reasons that the physician has an order not to immunize the patient. The patient may have an acute febrile illness, and the patient may not or should not be vaccinated should be vaccinated if contraindications end. You would code 4 if the patient or responsible party legal guardian chose not to accept the influenza vaccine after it was offered to the patient. You would code 5 if the patient or responsible party legal guardian were not offered the vaccine. And code 6 would be reported if the vaccine is unavailable at the facility due to a declared vaccine shortage. And just a note here that the patient should be vaccinated once the facility receives the vaccine. You would code 9 if none of the above listed reasons described why the influenza vaccine was not administered. This code is also used if the answer is unknown. Just wanted to give an example about a patient who perhaps received a vaccination in an acute care hospital, because I know this is the kind of questions that we get on the help desk. We've already started to get some questions. So for a patient who received the vaccine during the acute care stay immediately prior to an IRF stay or soon before an IRF stay, you would code 00250A. Did the patient receive the influenza vaccine in this facility for this year's vaccination season? The answer would be no, because the patient did not get the vaccine in your IRF. For the second item, 00250B, this item would be skipped because the first answer was no. The next item, 00250C, if the vaccine was not received, state reason. So the code you'd be reporting is 2, received outside this facility. Again, it could be the patient received it in a building that was the same building as you, but because you are an IRF, you are a different facility in terms of reporting this measure. So again, rationale, if IRF unit is the distinct part unit, if you're paid under the IRF PPS, then is considered a separate facility from the acute care hospital. Therefore, you're reporting if the patient received the influenza vaccine in your IRF unit. Just wanted to share with you some additional resources related to influenza vaccination. So you can get more information at the CDC website, www.cdc.gov/flu. Facilities should follow the Advisory Committee on Immunization Practices, the ACIP recommendations, to inform standard of practice regarding influenza vaccination. In 2010, the Advisory Committee on Influenza Practices first recommended annual influenza vaccination for all persons aged 6 months and older in the U.S. And as of 2013, the Advisory Committee on Immunization Practice continues to recommend annual influenza vaccination for all person aged 6 months and older in the United States. And the website provides the specific guidance in more detail. So that is the end of this presentation. So I think, is Charles nearby? I think we will stop here. I'm not sure that we've had questions, so.
Actually, I'm going to ask that you take one more small break here. I just have to stay on schedule. We're a little ahead of schedule here, so, and then we'll give the last lecture of the day, which is going to be on the readmissions measure. And then we'll finish up with the final question and answer period. I have several more questions that I can speak to, and we'll go from there. So if you could return to the auditorium by 3:40, we'll finish up. Thank you. All right. We are back for our last presentation of the day. And our last presentation has to do with the all-cause unplanned readmission measure for 30 days post-discharge from IRFs. And we have another remote presenter. And on the phone, I have Lori Coots. Lori Coots is a health service researcher at RTI International. Her primary research interests are in post-acute and long-term acute care, particularly around the issues related to quality and payment. She's worked alongside Dr. Mel Ingber as a co-task lead on the RTI readmissions team to develop readmission measures for the Medicare population utilizing post-acute care. So she's going to continue with this presentation, and after that we will finish up with some questions and answers. All right, Lori, you can take it away.
Great. Thank you, Charles. Good afternoon, everyone. So as Charles mentioned, next we would like to provide an overview of a new quality measure that is part of the Inpatient Rehabilitation Facility Quality Reporting Program. Next slide. The name of this quality measure is the All-Cause Unplanned Readmission Measure for 30 days post-discharge from inpatient rehabilitation facilities. Next slide. Reducing readmissions among Medicare beneficiaries is an important policy goal for the Centers for Medicare and Medicaid Services. Recent analysis conducted for CMS showed that the unadjusted readmission rate overall back to a more intensive care setting, including either a short-stay acute care hospital or a long-term care hospital following discharge from an IRF, was 15% nationally among the Medicare fee-for-service population. CMS goals are to reduce readmission rates post-IRF discharge that are inappropriately high and to improve patient safety and quality of care. To achieve these goals, CMS has developed the All-Cause Unplanned Readmission Measure for 30 days post-discharge from IRF. This measure will allow CMS, as well as providers and patients, to monitor readmission rates and evaluate the quality of care for this setting. This measure is part of a larger family of readmission measures that are currently being publicly reported or will soon be publicly reported for hospitals and post-acute care settings, including skilled nursing facilities, home health agencies, and long-term care hospitals. Next slide. This measure estimates the risk-standardized readmission rate of unplanned all-cause hospital readmissions to either a short-stay acute care hospital or a long-term care hospital within 30 days of discharge from an IRF. This measure looks at unplanned readmissions. We obtained extensive clinical and expert input in order to develop a list of planned procedures that are excluded from this measure. Our list of planned procedures is consistent with the hospital-wide readmission measure that's currently reported on Hospital Compare. However, we also added many procedures specific to post-acute care. Examples of planned procedures are removal of devices or amputations, but there are many others that count as planned readmissions, which are excluded for this measure. The method used for risk standardization is similar to the methods used for other readmission measures that the Medicare program currently is utilizing. The predicted risk-adjusted rate for each facility is calculated and then compared to the expected risk-adjusted rate if the same patients were treated at an average inpatient rehabilitation facility. The risk adjustment of this measure is essential in order to level the playing field for providers that may treat sicker or healthier patients on average. The process of risk adjustment ensures that providers' readmission rates for this quality measure are standardized. The risk adjustment models are fairly complex in order to take these patient factors into account. We use a number of risk adjusters, including principal and secondary diagnosis for patients' comorbidities based on the prior acute care claim. We include risk adjusters for surgical patients. We account for case mix groups, or CMGs, to capture the patient's reason for rehabilitation as well as their function at admission. We also account for prior utilization, such as ICU use and number of prior hospitalizations in the past year. Next slide. Because the measure tracks patients for 30 days after discharge from an IRF, It will provide information to providers that is not easily available to them currently. Readmission rates are related to quality of care, particularly in the transition from the hospital to the next care setting. Though facility-level readmission rates are not expected to be zero, elevated risk-adjusted readmission rates are indicators that there are opportunities for improvement in patient care and transitions of care. This readmission measure was submitted to the National Quality Forum for endorsement in February of this year. On slide 5 of the presentation, we include a link to the measure submission form to NQF, which includes additional materials about the measure, including details on the risk adjustment model. Next slide. Slide 6 includes a link to an additional resource. The measure specifications for this readmission measure are also posted on the CMS website at this link. Next slide. Finally, we include a diagram here, figure 2 on slide 7, that illustrates the readmission window to underscore the nature of this measure. Note that the measure requires a prior short-term acute care stay, followed by an IRF admission within up to 30 days of acute care discharge. Only discharges from IRF to lower levels of care, such as the community or skilled nursing facilities, are included in the measure. The patient is then followed for up to 30 days post-IRF discharge. And in this example, we have a hypothetical patient that had an unplanned admission to either a short-term acute care hospital or a long-term care hospital during this 30-day post-IRF discharge readmission measure. And this is counted as a readmission. Next slide. So that concludes our brief overview of the all-cause unplanned readmission measure for 30 days post-discharge from IRF. We have time for questions now or as well in the Q&A session that follows.
Okay, thank you, Lori. And I'll tell you what, we're having people submit written questions today and via email. So I don't think we're going to get very many questions on readmissions at this time, but what we'll do is we can address those separately and then include them in the FAQ documents. So thank you very much for your presentation. I'm just gonna lastly here go over some questions that were asked earlier in the day that we didn't get to previously, and then we can wrap it up for the day. I've had several questions that were asking about mandatory quality indicator IRF-PI items versus voluntary items. And so I first want to say that there is an item matrix that's located within the Chapter 4 IRF-PI Quality Reporting Program Manual. It's the IRF-PI manual. However, Chapter 4 is the section that we use to distribute information on the quality indicator items that are used to collect quality measure data for our measures. And the mandatory voluntary item matrix is located within that file. So, and that's located under the training web page. So if you go to the IRF Quality Reporting web page, the main web page, and then you select the training web page in the upper left-hand corner of that main web page, you can find the manual as well as this voluntary mandatory matrix under the downloads section of our IRF Quality Reporting Program training page. Anybody that still happens to have trouble finding it, just shoot us an email to our help desk. We'll be happy to send you a direct link to it. That's that. I had a few other questions here. I had one question asking us to clarify, is the 3-day observation period either 3 calendar days, with admission being day 1, or is it 72 hours from the time of admission? So it is actually the 3 calendar days. So the date of admission is always day 1, and day 1, or the date of admission, plus 2 calendar days encompasses those 3 calendar days. Another question asking, can you please confirm that M0210, in the item M0210, does the patient, which asks, does the patient have one or more unhealed pressure ulcers, staged 1 or higher, admission and discharge? Does this include unstageable as well as suspected deep tissue injury? And it does. And I know this person specifically noted in this comment that the way it's worded, it doesn't seem to include these. But I just want to explain, M0210 is what's known as a gateway question. So when you answer that question positively or negatively, it decides whether you're going to skip the rest of the pressure ulcer question. So if you were to say no, and then one of your unstageables or your suspected deep tissue injuries opened and you were able to stage them at some later date, you wouldn't be able to record them here. So it is a gateway question. You would include it. You would answer it yes if you had any of those stage 1 or higher actual pressure ulcers that you identified and staged as such, or an unstageable that might open later. And okay, this question asks or states, it is unclear to me from the presentation if reporting of stage 1 pressure ulcers and unstageable pressure ulcers are mandatory or voluntary. Please clarify. I do want to, I'm going to answer this, but I want to first state that you always need to refer to the mandatory versus voluntary matrix, item matrix, for each individual item. As a general rule, information about stage 1 pressure ulcers is voluntary, and unstageable pressure ulcers is voluntary as well. However, there are a few items that do refer to these that may not be voluntary. So I'm going to ask that you always refer to the voluntary mandatory item matrix when deciding whether or not to answer an item, and also the data submission specifications. All right, those are all the questions that I have today. If we chose not to answer your question, or we haven't answered your question yet, I just want to let you know that we certainly will get to it. We will include it in one of our FAQ documents that we post on the IRF Quality Reporting website. We will answer all questions. Some of them we may just want to clarify ourselves, or understand maybe a little further, or seek some further clarification from the writer of the question. And if that's the case, we have approached you and asked for your name and so forth. So I want to thank everybody for attending today. Really appreciate your attendance in person. And those of you that are viewing via web stream, really appreciate your attendance and your submission of questions through our email system. Again, if you have continued questions about the training aspects of this IRF Quality Reporting Program, we encourage you to submit as many questions as you like. I can assure you we won't only want success for you as providers as far as this quality reporting program goes, and we will work to get you there. So please submit the questions you need. Continue to check our website for updates with the quality reporting program side, also the technical side, which is a release of the IRF and data submission specifications and so forth. So, and we will be in touch, I'm sure. Take care.